Welcome back to another Masterclass Explainer. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. So, today, we are undertaking an absolutely critical journey. We're going to master inpatient clinical documentation by building what we call the pyramid of specificity. It's all about taking that raw medical data and transforming it into coding that's accurate, compliant, and honestly, financially viable.
Let's just dive right in, because at the end of the day, poor documentation directly equals lost revenue and major compliance risks. In the world of healthcare revenue cycle management, a physician's exact words are quite literally tied to the hospital's financial health. Vague terminology? Well, that can cost a facility thousands of dollars for just a single admission. Crazy, right? So our goal today is to understand exactly how that happens and, more importantly, how we can prevent it. Here's our roadmap to mastery for today. We'll start with the foundations of the IPDRG system, untangle the principal versus primary diagnosis trap, look at comorbidities and complications, dive into present on admission rules, tackle sequencing sepsis, and wrap up with effective CDI queries. Section 1. Foundations of the IPDRG system. Without understanding this base layer, the rest of our pyramid just won't hold up. The IPDRG, which stands for Medicare Severity Diagnosis Related Group, is really the beating heart of inpatient reimbursement. Essentially, it's a classification system that groups hospital inpatient stays into categories based on clinical characteristics and expected resource consumption. Ultimately, this system dictates exactly how much a hospital gets paid by Medicare and commercial payers. Think of the grouper logic engine as a giant, highly logical funnel. It takes all these raw inputs, the principal diagnosis, secondary diagnoses, surgical procedures, and even demographics like age or discharge status. It crunches all those clinical variables to map the patient into one of 25 major diagnostic categories, usually based on the affected organ system. From there, it splits the cases into medical or surgical partitions. It's a remarkably complex, automated decision tree that boils an entire hospital stay down to one defining code for payment. Moving on to Section 2, Principal versus Primary Diagnosis. Now, this is a critical distinction, and honestly, it trips up a ton of coders. The big takeaway here is this. The primary reason gets the patient in the door, but the principal diagnosis is what actually determines the MSDRG. The primary reason is just the chief complaint, say severe chest pain, but the principal diagnosis, that's defined by official guidelines as the condition established after study to be chiefly responsible for causing the admission. The entire DRG assignment hinges on finding out what that underlying condition truly was. Let's look at how this plays out in the real world. Imagine a patient comes in complaining of severe chest pain, but during their stay, an EKG reveals an acute myocardial infarction, and they end up having a major coronary procedure. Now, if a coder just blindly pulls chest pain from a vaguely written discharge summary instead of coding the established acute MI, well, it causes a disastrous domino effect. The major diagnostic category is wrong, the DRG is completely wrong, and the hospital faces massive revenue loss, all because the true principal diagnosis wasn't accurately captured. Section 3. Comorbidities and Complications. So, MSDRGs often use what we call a triplet structure. This is designed to account for how sick a patient really is based on their secondary diagnoses. If there are no additional complications, the stay falls into the lowest payment tier. Add a complication or comorbidity, a CC, and you add moderate severity, moving reimbursement to the middle tier. But if you add a major complication or comorbidity, an MCC, that signals high severity and heavy resource use. That bumps the payment to the absolute highest tier for that base condition. The impact of clinical specificity here is just staggering. Take a case with vague documentation, let's say unspecified pneumonia. That gives you a baseline relative weight of about 0.86. But if the physician explicitly specifies that the patient also had sepsis and diabetic ketoacidosis alongside that pneumonia, which is an MCC, the DRG changes entirely. The relative weight jumps to over 1.90. That single clinical clarification literally more than doubles the relative weight. Specificity is power, for sure, because it accurately reflects the intense level of care the team actually provided. Section 4. Present on admission rules. Timing is literally everything in inpatient coding. Just because a patient has a severe condition doesn't mean it counts toward the DRG, especially if it happened at the wrong time. Imagine a patient gets admitted with sepsis, and then 48 hours later, they develop an acute deep vein thrombosis, or DVT. Now, a DVT is generally a major complication that requires a lot of intensive management.
But here's the catch. Because that DVT developed after the patient was already admitted, its present on admission, or POA indicator, is flagged as an N, meaning not present on admission. Under CMS rules, this classifies it as a hospital-acquired condition. So even though it's a major complication, it cannot be used to increase the DRG payment. The system actually penalizes the facility rather than rewarding the higher acuity. It's a strict way to ensure quality of care and patient safety standards are upheld.
Section 5. Sequencing sepsis guidelines. Let's apply these stringent rules to what is arguably the most notoriously tricky area in all of inpatient documentation, sepsis. To code this correctly, you absolutely cannot just write the word sepsis and call it a day. It's like a puzzle. Step 1, you must definitively identify the underlying infection. Step 2, check if the documentation supports severe sepsis or septic shock. And step 3, you have to pinpoint the exact acute organ dysfunction, like acute kidney injury or respiratory failure, that actually makes the sepsis qualify as severe. The official guidelines demand absolute clinical precision here. You must always sequence the underlying infection, say sepsis due to E. coli, before you code the severe sepsis itself. On top of that, you can only code severe sepsis if the provider explicitly links the infection to the organ dysfunction in their notes. Antiquated vague terms like urosepsis or bacteremia, they just don't cut it in modern coding. The documentation must explicitly establish that cause and effect link. If it doesn't, that severe sepsis code and the massive weight it carries just completely drops off the DRG.
Section 6. Effective CDI queries.
So how do we fix documentation gaps when they inevitably happen? Well, this is where the Clinical Documentation Improvement, or CDI specialist, steps in. When documentation is ambiguous, lacking severity, or maybe even conflicting, CDI specialists intervene to clarify the absolute clinical truth. If a chart just says history of stroke, a coder might miss the true complexity of the case. But if you ask the physician to clarify if it was actually a history of cerebral infarction due to embolism, that changes the entire coding landscape. It paints a much more accurate picture of the patient's risk profile. That being said, a compliant query comes with incredibly strict rules. It has to be completely non-leading. You can't just nudge a doctor to document an MCC so the hospital gets paid more. No way. You have to present all clinically reasonable multiple choice options based on concrete lab results and vitals. And crucially, you must always include an option to leave the chart exactly as is, which is the no change to documentation option. For example, if respiratory failure is vaguely documented in the progress notes, the coder is essentially stuck. To resolve this, a compliant multiple-choice query should ask the provider to specify the exact acuity. Is it acute, chronic, acute on chronic, or is it clinically undetermined based on the current oxygen levels and treatments? Asking this in a strictly non-leading way bridges that critical gap between the raw clinical event on the floor and the final, accurate DRG assignment that gets billed. At the end of the day, precise documentation and coding are what truly defend both accurate patient care tracking and the hospital's financial health. It's a really delicate yet vital balance of clinical knowledge, deep guideline comprehension, and proactive communication. Coders and CDI specialists, you guys are the ultimate defenders of clinical truth. So I want you to think about this. Next time you review a chart, will you see just a list of symptoms? Or will you dig for the complete clinical story that drives the entire system? Keep decoding. And if you are enjoying this lesson, please like, share, and subscribe to this channel. And share it with friends for this free course on Decode Healthcare with Harshal. I'll catch you in the next masterclass.